Okay. Dear colleagues, good afternoon. Good afternoon to those are with physical presence. Hopefully they will increase in numbers. And thank you those that are connected. Today we are very honored that we have Professor David Ippolito. Professor Ippolito has made many times this honor class. He's coming every year. You know him and probably you love him because he's a great speaker and a nice guy, but a great speaker. So we are very flattered that we have you, Professor Ippolito, here. One year later after your previous presence. And as you know, Professor Ippolito is doing a lot of stuff. Among them is doing something on pediatric radiology. Although he is well known and it's an ESCAR member, however, he is doing with pediatrics as well. I would like also to welcome Professor Dulia. Dr. Dulia was elected in our university as an associate professor, and we are looking forward to have here with us. So you told me that you know Professor Ippolito, so he will comment on those. And not to lose time, because the topics are big, really big, and extremely interesting. The first one is pediatric imaging in the emergency setting. This is a series of books.
Yes, exactly.
And the second one is fundamentals of neonatal and pediatric imaging. So thank you very much.
Thank you, Professor Parsopoulos, for the really kind introduction. You are really kind with me every year, and I love to be here. This beautiful location, and really important university. And nice to meet you, Professor Dulia. And I hope that we will see maybe in the future, who knows, we will meet in presence. And I would like to thank Professor Hatzidakis as well to invite me as a speaker.
No problem.
And unfortunately, this year I have a really challenging topic because switch to the presentation. Because we have to talk about pediatric imaging, but unfortunately, since the topic is quite wide, I tried to create a sort of outline about the most important topic that I can try to cover in the next hour. And so the outline of presentation is dedicated mainly to a review of imaging techniques in emergency setting and in elective setting as well, in order to understand which could be the strengths and the limitation of each modality. And we try to improving the appropriateness of imaging indication, but obviously we have to spend some few words regarding the radiation, those issues. And obviously, I think that we will enjoy with a lot of practical pictures, most of them for our emergency department. So when we talk about pediatric pathology, I think that we have to distinguish two different ways of evaluating child. Those cases of emergency and those cases of non-emergency. Why these differences? Because the behavior of radiological imaging is quite different. So when we talk to the emergency, the most commonly used imaging techniques are represented by X-ray, ultrasound, and computed tomography, while MRI is mainly reserved for neuroradiological emergency, even if I know that in some centers all around the world, the MRI can be used for the acute appendicitis. But unfortunately, in most of the European centers, we do not have the availability of dedicated staff for 24 hours for 7 days. And for this reason, we prefer to do ultrasound or CT in some specific case. Well, the X-ray represents usually the first line modality for the chest disease, for skeletal trauma, and for detection of bowel obstruction or foreign body detection. The ultrasound, while the ultrasound is the first line imaging modality for most abdominal conditions like the appendicitis, lymphadenitis, ovarian torsion, and so on, or urinary tract infection. And usually it is preferred to CT due to possibility to avoid the radiation dose exposure. And obviously, this technique, it is really important in emergency setting by using the fast approach. Finally, CT scan usually represented the second level modality in the emergency setting for inflammatory abdominal disease with a negative or unconclusive ultrasound examination for those patients with unclear clinical presentation, or again, for those patients with trauma. But when we work with CT scan, first of all, we should remember that we have to set our protocol according to the age and to the shape of the young pediatric patient, and we have to try to work in line with ALARA principle. So we have to try to use the lowest radiation dose as possible by obtaining the best quality of image as possible. Thanks. Well, another important point before talking about the possible different disease in pediatric patients, we should remember that the collaboration between radiologist and pediatric physician is essential to choose the most appropriate diagnostic pathway to avoid radiation dose for those kind of patients in order to obtain in the fast way the most correct diagnosis. But it's time to start with the evaluation of the different technique in the emergency setting, and we can start with X-rays. But before starting with X-rays, we should remember that unfortunately the children are different from the adults, but they are different from each other, mainly because to the differences in terms of age, and we can assist to different chest X-ray manifestation or shape of the organ according to the different age. And one of the most important issue and the limitation is represented by TIMOS. And let's start with this example of two different X-rays from two different pediatric patients. In the upper part, we can see a 3-year-old patient. In the lower part, a 12-year-old patient. And even if in both of cases we are in front of negative examination, the shape of the mediastinum is totally different between the two kinds of images, mainly due to the enlargement of the mediastinum in relation to the presence of the thymus. While for the older pediatric patient, the shape of the mediastinum and of the arches is more in line with an adult one. So we should consider that we have to assist to this time-by-time modification. And the thymic shadow, it is really important because we should be able to recognize this organ on chest CT, and we have a typical radiological examination that is represented by the sail sign that can be recognizable in the upper part of the mediastinum, but this sign is mainly evident when the anteroposterior acquisition is not perfect, but is with a little bit of rotation, and we are able to recognize this kind of radiological manifestation. So the sail sign and opacities with triangular shape. Well, which are the most important indications for chest X-ray in pediatric in the emergency department? The first one for sure is represented by we perform the chest X-ray in order to exclude the pneumonia. We can take the advantage of using anteroposterior or posterior anterior, and in most of cases we do not need to perform two different projections. Lateral view must be performed only if the anteroposterior is unclear. So if you are able to recognize the consolidation in one of the possible lung lobe, we can use only one projection. Moreover, we should remember that the really young patient usually suffer more than bronchiolitis or bronchitis than pneumonia. So in most of the cases, the chest X-ray can be really negative. Another possible indication is the foreign body inhalation. And again, we can use only one projection, and typically the object can recognize in the area of the trachea, like in this example of patient with changes inside the trachea. Or another possible indication is the pneumothorax, and usually the X-ray must be performed in the maximum expiration. But if we are in front to really young patient or neonatal patient that undergo positive ventilation and so they may develop pneumothorax, we should use the lateral acquisition with different decubitus according to the area suspected for pneumothorax. So for the newborn, the lateral view is mostly preferred compared to the typical teenager patient. Obviously, we can perform also the chest X-ray for trauma indication, and again, we can be in front of pneumothorax, hemothorax, of pneumomediastinum, and most of cases, one projection is enough to make diagnosis. And in most of cases, we avoid the ribs projection because we are able to recognize the rib fractures on standard chest X-ray. Another possible indication is the abdominal indication, and we do that for suspected bowel obstruction or perforation. And we have to rule out the most typical radiological sign represented by the air fluid levels and by the free subdiaphragmatic air. When we do the abdominal X-ray, we should perform two projections, both of them in anteroposterior, in one case in supine position, in the other case in orthostatism, so in standing, in upright position, because the upright position is mandatory to recognize the air fluid level and the perforation, so the free air in subdiaphragmatic space, while the supine position is mandatory to correctly localize the different bowel loops and stomach in the correct anatomical position. And again, if you are in front of a newborn or really a young patient, we can take the advantage of performing a lateral acquisition or tangential view. But usually, in this case, regarding the lateral, we use the left side in order to use the liver opacities as a contrast against the air. Sometimes we could perform the X-ray of the abdomen also for renal stones, for possible renal stones, but we should remember that it represents a second level imaging. And we should do that only in case in which the ultrasound is negative for stones, for pyelonephritis, and the patient is positive for history or family history of renal stones. In this case, we could be able to recognize the calcified renal stones on our examination. Finally, another typical indication, especially in a really young patient for abdomen X-ray, is represented by the search or the rule out of foreign body ingestion that must be first radio opaque. It can be present in different anatomical area. And as already said, don't forget to do the X-ray only in supine position, because the supine position reflects the correct anatomical site of the foreign body, and we can suggest the endoscopist to go and retrieve the object. We can do that only in case of stomach area and duodenum area. In the other case, we have to wait that the foreign body go away for natural way. And when we perform the X-ray, one most important tips, we should suggest to the radiographer and to the parents of the child to perform the X-rays with the similar foreign body that the parents suspected the children ingest, in order to compare the radiopacity between the different products. Because usually the plastic or the glass cannot be recognizable or has a different value of attenuation. So it is mandatory to perform the both analysis at once. And I would like to show one really strange case from our center. This was not anymore so young, it's a 20 years old patient with psychiatric disease that ingested a fork that was still present in the esophagus. We did it 6 months ago, so it's not so long time ago, and was one of the most strange case I have seen in my career regarding the foreign body injection. Another important application of abdominal X-ray is the suspected abdominal mass, because again, when we do the X-ray, we are able to localize the gas of the bowel segment, and we can recognize the absence of gas in some part of our anatomical region, like in this case of patient with left kidney tumor with nephroblastoma. And obviously, in this condition, it is mandatory to perform a second level examination like CT to correctly characterize the possible abdominal mass. Finally, another important application of X-ray in the emergency is represented by the skeleton X-ray. And don't forget to perform, in case of long bones, to include the joint above and the joint below. And if we are in trouble regarding the diagnosis according to the different age of patient, in order to avoid confusion with the physical plate, so with the growth plate, can be useful to make the contralateral X-ray examination, and in most challenging case can be useful to perform several additional projections like the oblique view. And let me show the most typical fractures of a pediatric patient, that is represented by the so-called green stick fractures. That is an incomplete fracture that involves only one side of the long bones, and it is quite typical and simple to recognize because we have a modification of the shape of the cortical bone with this typical triangular shape. But again, I would like to highlight the importance to performing several and different projections, because like in this example, we are not able to recognize any fractures in the anteroposterior view, while in the lateral one, we are able to recognize this spheroid fracture of the distal tract of the diaphysis of the tibia, and obviously as well, we are able to recognize this important complete fracture of the astragalus. As I already said, in some cases, if we are not confident with the final diagnosis, with the suspicion of fractures, we can perform the contralateral projection in order to confirm the fractures, like in this example of patient with incomplete proximal deficient fractures of the ulna, or we cannot confirm the fractures, like in this case, in which we are recognize the ossification nucleus of epicondyle, of the medial epicondyle of the omerus. So in most of the cases, according to the different age, it is really important to perform the same projection in which we have the suspicion of possible fracture. And finally, another tips. In some cases, especially in the emergency department, we could have some cases, some patient with nails that go through the shoes or through any possible part of our induments of our suit or shirt. Before eliminate and throw away the nails, it's important to do an X-ray in order to understand how much deep is the nail inside the body, in order to create a trauma from the procedure trying to put away or throw away the shoes. Another really famous fractures, sorry for the Italian word, is the Jones fractures. That is the typical fractures of the base of the fifth metatarsal due to an inversion stress that must not be confused with the secondary ossification center. Usually, the secondary ossification center, also called apophysis, has a vertical shape, while the fractures are typical as a transversal shape. So we should be able to not make any confusion, like in this example of patient with foot pain on the right side, on the external side, and we are able to recognize this transversal shape in line with the ossification nucleus, so it's a normal finding, and we can appreciate also the corticalization of the two different bones, and it's totally different from the typical transversal behavior of Jones fractures. But in this case, we have the fractures and the delocalization of the growing nucleus, the secondary ossifying nucleus. But it's one of the most typical mistake in the emergency department if we do not have enough experience in this field. And finally, regarding the fractures of pediatric patients, we should focus our attention on the physial plate, that is a radiolucens area along the metaphyseal region, and it represents the growth plate. In some cases, the fractures may involve the growth plate, and we have a typical classification called Salter and Harris classification, and the fractures that involve this area are challenging for the diagnosis and can represent a big issues for the prognosis of patient, because the growing plate is fundamental for the growth of the bones, and so must be correctly recognized and correctly treated as fast as possible. Usually, to remember the classification, we can use the acronym SALTER to make the correct diagnosis. Usually S stay for sleeve, for the typical first example of sleeving of the growth plate. Second one stay for above, and is the most typical fracture of the pediatric patient that origins on the growing plate and reach the diaphysis. L stay for low, that involves the epiphyseal region. T stay for through, so it means that involve the epiphysis, the diaphysis, and the growth plate. And finally, ER stay for erase, and it means that the growth plate completely disappear. The first one and the last one are the most challenging and the most complicated one. And for this reason, we should perform in most of cases the contralateral projection in order to be able to make the correct diagnosis. Another possible indication regarding the skeletal X-ray in pediatric patient is the acute hip pain, and we should remember two of the most important fractures: the slipped capital femoral epiphysis and the leg calvé-perthes disease, that are quite similar, but we should be able to recognize by using a specific projection that is called frog leg view. Another possible cause of acute pain could be the osteoarthritis and the osteomyelitis. If you are in front of infection, the early X-ray is almost negative. So in case of osteomyelitis, we should take the advantage of using MRI, because it presents a higher sensitivity in recognizing the bone involvement and the soft tissue involvement from the phlogistic phenomenon. While in case of septic arthritis, we suggest to perform the ultrasound in order to rule out the presence of joint effusion. But going back to the acute hip pain, I would like to show two typical examples of left slip capital femoral epiphysis. In this case, you will recognize the typical anteroposterior view, and the slip capital femoral epiphysis is a typical type 1 fractures through the physial plate. And when we do the leg frog, we are able to appreciate the slipping of the head if compared to the neck, femoral neck structures. While in case of leg calvé-perthes, we are able to recognize the typical flattening of the femoral head. It is an idiopathic avascular necrosis. And again, it's important to recognize this entity, but in case of leg calvé-perthes, we could be able to compare the different shape of the two different femoral epiphyses. And this is another example of a 13 years old obese male with a knee pain and with typical left slipped capital epiphysis. We can recognize that the axis of the femur with the head is totally disaligned. And so the leg from view, it's mandatory to make the correct diagnosis. Finally, some young patients may suffer from the so-called accidental fractures, but please don't forget that exists the so-called non-accidental injury, also known as child abuse fractures. And they are quite typical as radiological manifestation because they manifest themselves as multiple metaphyseal fractures. We can recognize unusual epiphyseal separation, and this is mainly due to the shaking of the baby, and the arms has no axis and tend to develop fractures. And another typical sign is the multiple ribs or vertebral fractures, again to the shaking movement. So it is important to recognize this kind of fractures. Another typical site is the skull fractures, because in most of cases the parents push the baby against some hard structures, and so they can develop several different fractures. And while for the ribs, it's quite typical when we push or when we shake the baby to recognize this kind of pathological alteration. Another typical sign of child abuse is fractures over previous fractures. So if you are able to recognize in our emergency center that every month or every several weeks, the patient come back with the fractures in the same site of the previous one, with some ossification, we should suspect the child abuse, and we should alert our colleague, our pediatric physician. And again, this could be quite common, and if we don't know these entities, we cannot save the child, because in most of cases, it's the radiologist that understand of the child abuse. But now let's move to another topic, that is the ultrasound examination in the emergency department. As we can see in this line, we have several pathological conditions that can be recognized with ultrasound, but I will focus my attention on the most common one that are, again, quite typical in the emergency. Starting with the hypertrophic pyloric stenosis, that is a condition in which the muscle of the pylorus becomes abnormally thickened, causing the narrowing of the outlet of the stomach. And so we should perform the ultrasound acquisition typically with the linear probe, and we suggest to perform the ultrasound before and after the infant feeding, because the dilation of the stomach may help us in making the correct diagnosis. In most of the book, everybody suggests to use the liver as acoustic window, but for my clinical experiences, I prefer to put the baby in the right side position, because the gravity and the fluid that go through the pylorus can be more evident when we do the ultrasound examination. The typical sign that we should use to making the diagnosis of hypertrophic pyloric stenosis is the muscle layer thickness, higher than 3 millimeters, the pyloric diameter, so the transmural thickness more than 12 millimeters, and the length of the pylorus more than 15 millimeters. So this sign presents a very high specificity and accuracy in making the correct diagnosis. And let me show a recent example again from our center with a 1-month-old infant that was presented to our emergency department with recurrent vomiting after feeding. We performed the ultrasound examination in order to rule out the hypertrophic pyloric stenosis, and looking at our images, we are able to recognize the typical thickening of the wall of the stomach, of the pyloric region, with muscle hypertrophy, elongated and thickened pyloric channel, and the measurement were in line with the diagnosis of hypertrophic pyloric stenosis. And during the feeding, we were not able to recognize the pathway of the milk from the stomach through the duodenum. So the diagnosis was confirmed, and the patient underwent surgical experience. The other great chapter of emergency condition is represented by the intussusception. That is a medical condition in which one bowel segment slides on the adjacent segment, and so it created the typical bowel obstruction, but it created the typical radiological sign that is called target sign, because we are able to recognize circle over circle and multiple layer of bowel wall due to the slide of the two different bowel segments. The most typical site is the ileocolic intussusception. We should we should use the linear ultrasound, and we should also use the Doppler in order to recognize the multiple circular hypervascularization. But the typical sign, as already said, is the target sign or the layered sign, which we are able to recognize multiple different layers of small bowel intestine. In the past, when I was really young, in our center was quite common to perform the barium enema study in order to solve the intussusception, but now we are not able to perform anymore in the emergency due to the high amount of examination, and unfortunately we have to address the patient for the endoscopist to solve in a different way this kind of pathology. But usually the barium enema, due to the high density, works really well, especially in the really young pediatric patient. And let's move to the most famous pathology of pediatric patient, that is represented by the appendicitis. Don't forget to perform the ultrasound examination only after the laboratory examination, because the laboratory examination must support our diagnosis in order to making the correct differential diagnosis with other entities like the ovaric torsion, or like the pyelonephritis, or the stones, or the mesenteric lymphoadenitis. The examination must be performed with ultrasound, with a linear probe, and unfortunately, we are not able to recognize the appendix in all of patients, because in 1/3 of the 30% of patients, we could have an atypical presentation, and the appendix can be in a different anatomical localization, maybe in a retrocecal space. That is quite common. But how can we do the diagnosis? We can have some typical ultrasound sign. The first one is the non-compressible appendix. We should measure the transmural diameter that must at least 7 millimeters or more. If we are lucky, we can recognize the typical appendiculitis, and we are able to recognize the typical periappendiceal fluid, and the bright appearance of the perivisceral fat. They are quite common, also associated with enlargement of lymph nodes. When we use the Doppler, we can appreciate the increase of vascularity along these linear structures that is the appendix. As already said, in some cases, like in this one, we cannot so lucky with ultrasound, and the appendix can be in a really different anatomical site, like in this case that was in the deep in the pelvic space. We are able in this case to recognize also the perforation with an abscess along the apex of the appendix, but usually the ultrasound could be enough. If ultrasound is negative, we suggest to perform the unenhanced CT scan. If we are not able to recognize any abscess, we can make the diagnosis without contrast agent. If we have the suspicion of abscess, or if we have a perforation, it is better to complete the examination with contrast agent to increase the prognostic value of this technique. The murine appendicitis could be used, but it depends mainly on the availability, so according to the different center. And most important things, we need a dedicated staff, and since the examination can last 15 minutes, we deserve the compliance of patient to perform the examination. And for this reason, in some cases, we need the sedation, and so we prefer to avoid that and do ultrasound plus CT when needed. Another possible application of ultrasound examination for sure is represented by the urinary tract infection. The ultrasound represents the first line imaging modality, especially to recognize the pyelonephritis. That is represented by rounding hyperechoic alteration along the cortex of the kidney. But if we are in front to abscess, we can recognize anechoic rounding alteration. In all of the cases, again, it is important to perform the urine collection before the examination in order to avoid any misdiagnosis. And obviously, in all of the cases, the urinary bladder must be well distended. And if we have the suspicion of stones, we can complete the examination, as already said, with abdominal X-rays. Another important emergency condition for pediatric patients is represented by testicular torsion, and we should use the ultrasound examination to make the correct diagnosis, but unfortunately, maybe in early phase, our examination could be negative. And so we have to wait at least from 6 to 24 hours in order to recognize the typical asymmetric echogeneity between the right and the left testis. And usually we are able to recognize some edema inside the testis, or we can recognize the reduction of Doppler vascularization for the pathological testis. And another typical sign is the Mickey Mouse sign, which we are able to split the testis with two different colors, with hypoechoic or with a normal echoic area and hypoechoic area that is in line with necrotic phenomenon. In some cases, we can be also able to recognize the typical Whirlpool sign of the spermatic cord that must be recognized as fast as possible. Only in a really delayed case, the testis may have a really atypic echogeneity due to the necrotic phenomenon, but fortunately is not so common. The most important differential diagnosis of the torsion of the testis is represented by torsion of the appendix of testis that has more or less the same kind of findings. Usually in an acute phase, we are able to recognize the really thickened appendix of the testis with an hypervascularization due to the inflammation and torsion at once if compared with the contralateral. And another possible differential diagnosis is the orchitis or epididymo-orchitis. And in this case, we are able to recognize the thickening of the body or the tail of the epididymus that is typical, really large, and if compared to the contralateral one. And again, if we use the ultrasound, we are able to appreciate the significant increase of vascularization. Again, this is quite typical in pediatric patients, but in the emergency department, also in the elderly patients. So they have in common this kind of entities. Obviously, we have also the correspective of testicle torsion with ovarian torsion in female patient. And in this case, the diagnosis could be a little bit simple, because if we are able to recognize the enlarged ovary with a minimum diameter of 3 centimeters and with presence of debris fluid level due to the blood inside, we can perform the correct diagnosis. If we are lucky, we can be able to recognize the Whirlpool sign of the vascular pedicle, but maybe in some cases can be really challenging. If we are not able to recognize the ovary with the ultrasound, in some cases we address the patient directly for CT scan. And again, on CT, without contrast, we are able to recognize immediately the enlargement of the ovarian structures with significant hyperdensity due to the blood content. That is obviously highly suggestive with ovarian torsion diagnosis. But don't forget that in some cases, we can also recognize some underlying lesions that are the cause of the torsion, like the typical young teratoma. Moreover, in the emergency department, we have another typical region that must be analyzed with ultrasound, that is represented by the cervical area, because usually most of the pediatric patients suffer from infection and may develop cervical lymphadenopathy. The ultrasound examination represents the first line modality, but should be used only after the antibiotic therapy. Because even if we can do tons of examination during our emergency shift, so we suggest to perform after the therapy. And we have some typical signs that allow us to make the diagnosis. The first one is the enlargement of lymph nodes. The second one is the increasing of the Doppler vascularity. And third one is some specific anatomical location. Usually, the lymph nodes has a specific shape. They are an oval shape. They have an homogeneous echogeneity of the cortical area. They are characterized by hyper-echogeneity of the hilum. The short axis usually is left of 8 centimeters, and at the Doppler examination, we cannot appreciate any vascularization or only hilar vascularization. In case of phlogistic phenomenon, we cannot recognize the hypovascular or hilar vascular pattern, and we can appreciate the significant hypervascularization, and the Doppler can reach also the most distal part of the cortex of the lymph nodes. The typical chains that are involved in case of cervical lymphadenopathy are the jugular and the retroauricular and occipital one, while the submandibular one usually are really huge in all of patients, and so the dimension is not so important in making the diagnosis of infection. Finally, unfortunately, if we are in front of really enlarged lymph node without any possible hilum, we should remember the differential diagnosis of lymphoproliferative disease. But in this case, we can appreciate a really peripheral hypervascularization more than hilar vascularization. And moreover, we can have, in some cases, some specific pattern called the paving pattern due to the high amount of lymph nodes that are one close to the other one, that looks like a mosaic floor. Let's move to the last technique that we can use in the emergency department, that is represented by the computed tomography. We should use the computed tomography in order to solve the problem in case of doubtful diagnosis with ultrasound, like already said, I don't know, for ovarian torsion or for appendicitis, or in some cases for pyelonephritis. But one of the most important applications is the severe trauma. This is an example of a bicycle trauma in which we did this scan in really young patients. And in most of the cases, we need not only the unenhanced CT scan, but we deserve also the contrast agent in order to correctly characterize the possible parenchymal trauma and to recognize the different vessel and decide if we need to embolize or if we need to treat some bleeding in the spleen and the liver mainly. The traumatic pathology may also involve the brain. It's quite common, like in this 14-year-old boys. When we do the unenhanced CT scan, don't forget to acquire or to reconstruct the images with 1 millimeter thickness, because it allows us to correctly quantify the volumetric extension of the subdural hematoma that is mandatory both for the diagnosis and for follow-up. So don't use the typical 3 or 4 millimeter thickness, because in the other case, we are not able to correctly evaluate with multiplanar view the amount of blood. But we will see extensively the CT in the other part of presentation. I don't know if you are really tired or if you can continue with the second part. Is there any question from the emergency?
Actually, it's extremely comprehensive.
I try to the best part.
Very concentrated, but very well received and precise. So thank you. Maybe since the other topic is a little bit different, yes. If I will ask Professor Dulia if she likes to perform some comments, and then if there's any question, it will be welcome.
Thank you very much, Professor Ippolito, and we're very grateful for sharing your expertise and knowledge with us. Both of your presentations are very relevant to us who are doing pediatric radiology, pediatric emergencies, very common. I have one question about about trauma and the CT protocols that you're using in your institution. I know that you have extensive experience making safer CT protocols for children. And in my experience, we have been using the combustion protocol, which is the split bolus protocol, to obtain one CT acquisition with both arterial and portal venous phase in children coming with trauma. This is to reduce the acquisitions, CT acquisitions, and we think that in pediatric trauma, in most cases, this works very well. There are some cases where interventional radiologists may require separate arterial and portal venous phase protocols, like separate acquisitions. That is something that we decide on occasion, but the main protocol that we are using is what we call the split bolus protocol or combustion protocol. What would be your experience or comment on that? What is your experience with your center?
Thanks for the question. It's really important to say the radiation dose is mandatory. And first of all, in our center, we have dedicated protocol in terms of radiation dose, in terms of kV. Usually we work with 80 kV for pediatric patients because it allows us to save only with kV the 30% of radiation dose. But usually, since we work in a really huge trauma center, we prefer to use all the different contrastographic phase because we have our interventional team that would like to differentiate the pseudoaneurysm, the bleeding, or the portal venous trauma. So for us, it's really mandatory to have different contrastographic phase. What we do usually is the unenhanced CT scan, including brain first, and then lung and the abdomen. If the lung is negative, we can avoid to acquire with contrast agents lung and the abdomen again. And so if we have some free fluid in the abdomen, we do the arterial and portal venous phase only in the abdominal area. And we do also the lung in arterial and portal venous only in case of pleural effusion and so on. But we do not, our interventional radiologists and me as well are not so happy with the split bolus because we have a mix of attenuation and it's a little bit challenging to make the correct diagnosis. So we prefer to divide the different contrastographic phase, but obviously it depends on the habits of the different center. But if we use a low dose protocol, it could be better. And another really important problem is the delay of the contrastographic phase, because especially in a really young patient with 2, 3, or 4 years old, we have the possibility to acquire only one contrastographic phase because we do not have any fixed delay to acquire the perfect arterial or portal venous phase. And so in this case, after the unenhanced CT, after 35 seconds or 40 at least, we acquire the contrastographic phase. That is a sort of hybrid acquisition, half arterial, half portal, in order to have a good overall view of all anatomical and vascular structures. This is our behavior.
Okay. And regarding the follow-up, after CT trauma, do you use the same type of protocol or as the acute presentation, or in the follow-up it's more tailored to the injuries that you have discovered at the first presentation?
Exactly.
What is your experience with that?
We tailor the second acquisition according to the main diagnosis or to the main trauma. In most of the cases, we do only one portal venous phase during the follow-up in order to see the possible recovery of the different organs after the treatment.
And thank you very much. And I know that many Italian centers, they are using also contrast-enhanced ultrasound, either as a first-line modality or for follow-up in trauma cases. Do you have any experience with contrast ultrasound in children in the trauma setting?
We do not use that. Sorry for that, but unfortunately, since I work in this huge trauma center, we have 3 different steps of analysis, because when my resuscitation team go to take the children during the injuries, they do the ultrasound on the streets. They do another ultrasound on the helicopter or in the emergency area, and then we go directly to the CT area. So since we have 3 different steps, we prefer to avoid another ultrasound with contrast agent, wasting time maybe, and then do CT scan. We prefer to, after 2 different ultrasound made from different physicians, usually from the resuscitation team, we prefer to move to the CT if it is needed. And we can discern the contrast enhanced ultrasound in those cases that do not need any emergency procedure. So if the ultrasound is negative or not significant, then 24 hours later you can do the contrast enhanced ultrasound, even if we skip this part totally.
Thank you very much. That is very helpful insight. Thank you very much for sharing.
So is there any question from the audience? Comments? So let's proceed.
Yes, thanks. I don't know if Adam and his team prefer combined protocol, split bolus protocol, or different contrastive phase to this in order to decide how to treat.
There's so much emergency, and especially traumatism, because they go usually to hospitals with pediatric surgery.
Okay.
It's another hospital. So we see very rarely. And the problem is that they have pediatric surgery, but they don't have angiography. So that's the great tradition of Greek organization.
Okay. But you prefer, I suppose, the different contrastive.
You mentioned that before. If we would do an angiography, it would be better to have a real good arterial phase in order to not mix the phases and see obviously where the extravasation is coming. So I prefer your.
The intervention radiologist behavior of our center more than mine. There you go. This approach. Okay, we can go further. So I think that we can move to the second part of the presentation that is dedicated to non-emergency setting or elective setting. In this case, the possible used imaging technique should involve also the MRI, and also the computed tomography as a much more importance for the diagnosis and follow-up of patients. I'll try to share with you some of the most frequent experiences, especially in our center, and we can consider like common indication in hospitalized pediatric patients 2 kinds of the disease. The pediatric hematological condition, in which the lymphoproliferative disease represents one of the most big issues, and the complication that must diagnose it and followed with ultrasound, CT, and MRI. But we are also famous for several congenital metabolic disease, but it's a huge chapter, and it's not simple to describe only in this lesson. And we should consider another kind of indication for the hospitalized patient, that is the fever of unknown origin, and the diagnosis of inflammatory bowel disease, and finally the musculoskeletal disorder. I'll try to cover most of this kind of pathological condition, starting with lymphoproliferative disease. The dominant clinical expression in case of lymphoma patient is the increase in the volume of lymphoid organs that are represented by lymph nodes, thymus, especially for the most for the youngest one, the spleen or the Waldeyer ring. But despite this typical manifestation, we should not forget that lymphoma may involve any possible organ. So liver, peritoneum, testicle, and so on. In fact, in clinical practice, we have an involvement with a range from 25 to 40% of cases with extra lymphatic lymphoproliferative disease. Which kind of technique we should use to making the correct diagnosis, so the correct staging and follow-up of lymphoproliferative disease? For sure, the contrast-enhanced computed tomography is one of the most important, but in most of cases must be combined with the PET-CT scan, because the PET-CT is more sensitive in recognize the pathological lymph nodes localization. So we should combine both examination. Moreover, in some condition, we deserve further examination, I don't know, like the brain CT or better, the brain MRI, if we suspected a brain involvement from lymphoproliferative manifestation, or a scrotal ultrasound, or more in general, also the gastrointestinal imaging, including also the ultrasound as well. But let's start with a typical chest X-ray manifestation of mediastinal lymphoma that is characterized typically by an enlargement of the mediastinum that can be clearly recognized in the anteroposterior projection or in the lateral, on the lateral view. But the possible manifestation of lymphoma may have a really wide range of radiological manifestation. And the most typical sign is the sparing of the vessel. Even if we could have a really huge mass, we are able to recognize both arterial and portal venous vessel, because the lymphoproliferative tissues do not eat, destroy, or invade the vascular structures that can be, in all of the cases, clearly recognizable. And we are able, in most of the cases, to recognize the lymph nodes that can be enlarged. They can fuse each other, making the so-called bulky mass, and can be localized upper or lower regarding the diaphragmatic region. And usually we use the Ann Arbor classification in order to correctly classify the lymphoproliferative manifestation. And again, this is another typical example of abdominal lymphoma, and we can appreciate the sparing of the aorta and of renal arteries. And since the chapter is quite wide, I would like to show, again, a really recent example from my center 3 months ago. A 5-year-old boy presented to emergency department with abdominal pain and clinical splenomegaly. For this reason, our colleague addressed the patient for a first-line imaging represented by the ultrasound, and we were able to recognize this huge mass along the hilum of the spleen with an internal vascularization that obviously was not clearly characterizable with ultrasound, and so we deserve a further imaging technique represented by the CT scan. And I'm showing you the results. In this case, we are able to recognize this huge mass along the hilum of the spleen. We are able to recognize other soft tissues on the hilum of the spleen, of the liver, sorry. We can appreciate some free fluid. In all of the cases, we are able to recognize the vessel inside the mass, and we were also able to recognize a soft tissue mass also in the deep pelvic region with the congestion of lymphatic structures in the peritoneum. So the possible diagnosis for us was a lymphoproliferative disease that was confirmed with biopsy that confirmed a Burkitt lymphoma. So don't forget that any time which we are able to recognize a huge mass that can involve several organs or only one organs associated with the lymph node enlargement, we should consider lymphoma. Moreover, at every time in which we are not able to making a diagnosis for pancreas, liver, spleen, with specific characteristics, we should think about lymphoma, because the lymphoma has a really wide range of manifestation. So we have some cases that looks like hepatocellular carcinoma and was lymphoma. We have pancreatic, looks like adenocarcinoma and was lymphoma. So we should rule out this diagnosis all of the time. And for this reason, the biopsy is mandatory, especially in really young patients where lymphoproliferative disease is really, really common, and especially in our center. Moreover, in those patients that underwent chemotherapy, corticosteroid therapy, and due to the immunosuppressive therapy, the patient may develop some respiratory symptoms. We can use the chest X-rays as first-line imaging modality, but I would like to show how different is defined from chest X-ray if compared with CT scan. Two different patients, both of them with Hodgkin lymphoma, and in both of the cases, the patient developed the typical Aspergillus flavus infection. And what we have to do in clinical practice, we have to rule out the presence of mycoplasma or Aspergillus infection, because they are really hard to treat. We deserve to use 3 different antibiotics to treat the lesion, and so we cannot rely our diagnosis in chest X-ray findings, but we have to complete the examination in case of positive or doubtful findings with CT scan. Like in this example, the left lung was completely negative, while we find a lot of consolidation, while in this case, on the chest X-ray, we were able to recognize these 2 rounding lesions, but behind the heart, we have a really huge abscess that must be treated and followed up during the therapy. And the most typical sign or the most typical infection of patient with lymphoproliferative disease is represented by the pulmonary mycosis. In some cases, we could able to recognize the fungus ball that was a really specific sign of fungus lung infection. And don't forget to complete the examination also with ultrasound, especially if we have some symptoms that could be related to the liver. So if we suppose that the patient may have a liver abscess due to alteration of liver enzyme, we can perform the ultrasound in the emergency. But for sure, the CT scan with contrast agent is more sensitive in recognizing huge and small possible abscess. And one of the most important complications is represented by the graft versus host disease of the bowel. That is quite typical in those patients. After the treatment, we are able to recognize an homogeneous thickening of the entire small bowel wall due to graft versus host disease. And it's quite typical in our clinical practice. Another possible complication of a lymphoproliferative patient can be represented also by pancreatitis. Again, let me show some example from our center. In this case, we are in front of a 2-year-old patient with acute lymphoblastic leukemia that was addressed to our emergency center due to the increase of pancreatic enzyme, increase of C-reactive protein, and the patient was suspected for acute pancreatitis. We performed the CT scan without any contrast agent, and typically we can recognize the fat deposition inside the liver due to the chemotherapy and corticosteroid treatment, and we are able to appreciate the increase in size of the entire pancreas with some free fluid in the retroperitoneal space and the presence of rounding hypoattenuating alteration in line with the localization of necrotic phenomenon. And this is another challenging case. Another patient suspected for pancreatitis. In this case, the CT scan was performed 18 days after the transplantation. And what we found was this rounding alteration with lobulated appearances just behind the head of pancreas. It was an ectopic pancreatic gland that undergo pancreatitis. It's a really rare event, but it can happen, like happens in our center. And so we should keep in mind then one possible complication can be also the pancreatic involvement, so not only the liver and the kidneys must be considered in clinical practice. Regarding the possible infection, don't forget that to correctly evaluate the brain infection and the brain lymphoproliferative disease, the MRI is the gold standard technique because allow us to recognize the focal lesion, but also the involvement of the different ependyma. And with contrast agent, we can better localize and delineate the possible phlogistic alteration or lymphoproliferative alteration as well. So we should preserve the MRI more than CT in this clinical condition. But let's move to another typical indication in our center, represented by the fever of unknown origin. What we should remember first, that is the imaging not play a mandatory role. It plays a secondary role. So we should use the ultrasound or CT and MRI once the clinical examination, patient history, and the laboratory findings narrow the field. So if they are in doubt, we have to complete the examination with different techniques according to the clinical suspicion. So if we have the suspicion of inflammatory bowel disease, the MR enterography, it is mandatory. If we have a suspected arthritis, we should use the MRI, obviously with contrast agent or ultrasound. If we have a suspected pneumonia, we should start X-ray and complete it with computer tomography. If we are in front of possible brain infection like toxoplasmosis, we should consider brain MRI, or if you are in front of pancreatitis, we can start with abdominal ultrasound and then move to CT scan. So we should use the correct technique according to the correct clinical suspicion. But let's start with one of the most important inflammatory bowel condition that is represented by the Crohn's disease. And we know that it is an autoimmune condition that can involve any tract of the gastrointestinal area, so the entire gastrointestinal tract. Most commonly, it involves the terminal ileum or the proximal colon, but we know that we can recognize the typical ulcer and thickening of the rectal wall, of the wall of the intestinal wall in different areas. Usually, we have different phases of the disease. We have the early stage of Crohn's disease that is characterized by lymphoid hyperplasia. That means thickening of the bowel wall, lymphedema, that means fluid in the submucosa area. And for this reason, when we do the CT scan in acute phase, we have the typical layered or target sign appearance due to inflammation and edema of the submucosa layer. In the progressive stage, we can recognize a really deep and longitudinal ulcers that if they go deep to the different bowel layer, they at the end create some abscess or some fistula, and they can extend also in the mesenteric tract. And finally, we have the chronic stage. Usually in the chronic stage, this patient may develop fibrosis or strictures that must be treated. So the most important question is, which kind of imaging we should use in patients with Crohn's disease? Because we could use the computer tomography, the MR, or the ultrasound, and all of them are able to offer several information. But we should consider that Crohn's disease has a different kind of manifestation. We have the active inflammatory or acute condition, the chronic fibrostenosis appearance, and finally the penetrating one. So usually the active inflammatory deserve only medical management, and in this case we can use MR enterography or CT scan in the emergency to make the correct diagnosis, while for the chronic and the fibrostenosis manifestation we deserve CT scan because this technique has the better anatomical evaluation, while in case of penetrating form, I think that the MRI is the best one because it is able to recognize abscess, fistula, and in some cases also CT may have a role. So in acute phase, ultrasound can be useful, but it's able to detect bowel wall thickening. But in some cases, due to the air inside the bowel lumen, we are not able to recognize the different localization from Crohn's disease. So it is useful when the bowel gas is limited and can be used for follow-up, but obviously it deserves a significant expertise. So in acute, the CT with contrast agent is one of the most used technique, important for the differential diagnosis, but we should consider the radiation dose that represents an issue. But in emergency, we prefer the CT without any preparation. While, and then I'm showing you a typical example of ultrasound examination of Crohn's disease localization. We are able to recognize the thickening of the rectal wall that is higher than 3 millimeters. We can appreciate the typical layered ultrasound structures of the bowel wall due to the edema of the submucosal space, and the increase of density of the fat, so the typical brightness of the perivisceral fat with increasing in size of the lymph nodes. While in subacute phase, so in order to assess the disease extension and for the follow-up, we have the possibility to use two different techniques. The MR, that usually is preferred because it has the best contrast resolution, has the advantage to avoid any ionizing radiation, but it requires a relatively long acquisition time, no more than 20 minutes for a standard protocol, but we should dilate the bowel loop by using an oral contrast agent. We can use also the CT enterography, but don't forget the preparation is the same, and so can be a little bit discomfortable for patients, especially if they have an active diarrhea. For sure, it is faster if compared to MR enterography, but again, we should consider the radiation dose exposure. And let me show what the differences between CT and MR when we are in front of a chronic phase, and so in which we have to assess the complication. The MR is more useful than CT because the MR relies on the relaxivity of the fluid, and we are the possibility to better recognize the fistula between the different bowel loop or between bowel loop and several organs like the urine bladder, and we can take the advantages of recognizing the abscess, and there is a special possibility for CT to make the diagnosis only in case of acute obstruction. So if we have a stenosis and we need the surgical option, we should rely on CT. In all or the other cases, in our center, we prefer to do the MRI because it's more sensitive and less ionizing radiation. Moreover, one of the possible complications of Crohn's disease is represented by the perianal involvement. And again, the MR is the best technique in order to recognize the perianal fistulas, because with the T2 weighted fat SAT sequences, we are able to recognize the linear perianal alteration. And when we use the contrast agent, we are able to differentiate between the active perianal fistula or fibrotic disease. And again, it is mandatory in order to decide which kind of surgical approach the patient deserves. And obviously, the MR has a special and better delineation for the muscle structures and the relationship between the fistula and the wall and the rectum and anus as well. Let me show other possible clinical indication or clinical manifestation of disease in newborn or early infant patient. Usually for fetal and early infancy, we should work with a multimodality approach. Ultrasound in any case is the first line modality that must be completed or followed by MRI, that is mandatory for the tissue characterization, while CT is mandatory only for the vascular assessment. So we should use CT in specific and selected cases. Let me show another example from our center. This was a 2-month-old infant that was born with this left lateral cervical mass. We do the ultrasound in the pediatric department, and what we found, a multi-loculated anechoic mass with this anechoic alteration full of septa and with some soft tissue inside. But unfortunately, we were not able to make the correct diagnosis because we were able to recognize some Doppler can be in line with lymphangioma alteration that is quite common in early or in newborn patient. But obviously, to making the final diagnosis, we need MRI study, and I'm showing the results. In this case, we can confirm the multi-loculated lesion on the supraclavicular left space, characterized by multiple septa. And after adding the contrast agent, we can appreciate the peripheral enhancement of the lesion in line with the suspected diagnosis of cystic lymphangioma. So the MRI can confirm any possible diagnosis. Let me show another example. Again, a patient with fetal abdominal mass that was detected in the left hypochondrium. Unfortunately, I was not able to bring with me the images from ultrasound, but the mass was quite hyperechoic, looks like a cystic mass, and was in the left hypochondrium, quite close to the diaphragm. Again, we were not able to make the diagnosis, so the patient was addressed for the MR, and now we are able to recognize this lesion that is localized in between or inside the left diaphragm, is predominantly T2 hyperintense, looks like a prostate, but it's not a prostate. It has an heterogeneous signal with presence of a solid component. And in this case, one of my colleagues that is dedicated to the to pediatric case suspected the extralobar pulmonary sequestration. We know that to make the diagnosis of pulmonary sequestration, we deserve the CT because the most specific sign is the aberrant arterial vessel from the aorta. And in this case, the patient at CT scan presented two different arterial aberrant structures. And so he confirmed the suspicion of congenital hernia that was confirmed after the surgical procedure with an extralobar sequestration. So this is a typical case in which the CT has only one specific indication. Recognize the really tiny vascular alteration that cannot be recognizable in MR, especially for this really small patient. Another possible manifestation of early infant mass can be represented by the Morgagni hernia. This was again a patient that was an abdominal pain with nausea and vomiting, and during the X-ray we were able to recognize this multiloculated mass that is colon that was localized in the mediastinal space. And again, could be another possibility for the newborn patient. Another entities that we should know in everyday clinical practice is the necrotizing enterocolitis. That is the most common gastrointestinal emergency in newborn. For this reason, when the patient are immature or newborn, we should perform the X-ray in order to rule out this entity. And we have some really specific sign that can be recognized with X-ray, represented by the bowel wall pneumatosis. So we are able to recognize this double layer along the wall of the small bowel. We can recognize the bowel distension. In the very advanced stage, we can appreciate also the air fluid level. And another really advanced sign is the portal venous gas, due to the pass of the gas from the bowel layer to the mesenteric vein structures till the portal vein inside the liver. And in most advanced case, we can recognize also pneumoperitoneum. But it's a really critical condition that must be recognized as soon as possible and treated as soon as possible. So the take-home message regarding the possible mass in newborn patient is that the multimodality imaging is essential for this kind of patient. Ultrasound alone is often not sufficient, while the MRI improves the diagnostic confidence. We should use CT only in selected cases for vascular information. But in a young pediatric patient that can be hospitalized, we should consider also the musculoskeletal disorder that are quite often, like the joint and muscle disease, like the osteoarthritis or the myositis. And again, in this case, I think that X-ray may manifest only in the late phase some specific sign. So we should use in the early phase the MRI. In the MRI, we are able to recognize immediately the fluid collection, the enhancement of the phlogistic collection. So it is the best technique to recognize the muscle and phlogistic phenomenon, like in this other example from our center, patient with the myositis of knee, in which we are able also without contrast agent to recognize the fluid collection inside the muscle and the relationship between fluid and increasing of laboratory reactive signs. We can make the correct diagnosis. Another important indication of the MRI for sure is the arthritis, because with MRI we are able to recognize first the free fluid, and when we administer the contrast agent, we have the typical hyper enhancement of the synovial space. And in the advanced case, in case of osteomyelitis, in which the arthritis involves the bones, we are able also to recognize the bone marrow edema with different entities and different enhancement. The most typical localization for arthritis are represented by the temporomandibular joints, the hip and sacroiliac joints. In none of these cases, we can start the examination with ultrasound, but later we observe the MRI, not only to confirm the diagnosis, but also to follow up the disease after the antibiotics therapy. The ultrasound obviously is non-invasive, it's quick with low cost, but again, we need a high amount of experience to make the correct diagnosis. One of the typical diseases in our center, since we have a lot of lymphoproliferative disease, is the bone osteonecrosis that is typical for patients after chemotherapy or that undergo high-dose steroids. In this case, we need only 2 sequences with MRI to make the diagnosis, 1 T1 sequences and 1 T2 fat subsequences, and we are able to recognize immediately the typical sign of osteonecrosis. The X-ray is able to recognize osteonecrosis only in a really late phase. So, in case of a patient with the lymphoproliferative disease and acute pain, we should address the patient for MRI, and we can recognize immediately the double layer sign that is characterized by hypo-intense linear in T1 and in T2 weighted sequences due to the granulocytic reaction surrounded by an hyperintensity. So the double line sign is really specific to make the diagnosis, and we need only 2 sequences to make the diagnosis in the different anatomical area. But unfortunately, the morphology is quite typical with the serpiginous shape and with a mosaic appearance. But since the osteonecrosis is quite typical in those patients with the lymphoproliferative disease, if during our MRI we recognize rounding lesion in a typical site without the double line sign and with an intermediate high signal on T2 weighted sequences, we should remember that the patient may develop a relapse of the disease. So when we are in front of a solid mass, think all of the time to the presence of residual lymphoproliferative disease, not only the osteonecrosis that is really, really common in those kind of patients. In our center, we have a really high amount of different entities. I would like to show the last one, that is the neurofibromatosis. In this case, I'm showing you the typical neuroplexiform fibroma. That is a really strange structures. When we do ultrasound, it looks like a lymph nodes. It's in between lymph nodes and venous variceal structures. When we do the MRI, we can able to recognize this mass characterized by multinodular appearance And when we inject the contrast agent, only after 7 or 8 minutes, the lesion is characterized by enhancement. So we do not have any enhancement in early phase or in portal venous phase, and we have to wait at least 5, 6, or 10 minutes to have the best enhancement of lesion. And it's quite typical with these appearances, with these targetoid appearances from different components. But regarding the metabolic disorder, sometimes we have also a strange case, like this patient with ESA dactylia, that is not so common. We have also the osteogenesis imperfecta. We are full of strange disease, but we are not able to cover everything. But the summary of this part of lesson is that we have two different entities, emergency and non-emergency. In the emergency, in most of cases, the X-ray represents the first line examination. In a non-emergency, we should take the advantages of brain MRI for the brain pathology, chest CT for thoracic pathology, abdominal CT and MRI for abdominal pathology, and MRI for skeletal disease. While in emergency, we prefer the X-rays. Finally, because reaching the end of the lesson, sorry for that, we should talk about the radiation dose in pediatric patients. Why this is important? Because the children are more sensitive to ionizing radiation than adults. They have a longer life expectancy, and so they can accumulate the risk of developing cancer due to the radiation dose. And for this reason, we should have a dedicated protocol according to the shape, the age, and the weight of patient, because one size does not fit all. And we have to justify every examination, optimizing imaging protocols, and, as already said, working in line with ALARA principle and will image gently. From 1998 to 2006, we can appreciate the significant increase in radiation dose exposure for pediatric patients, and mainly derived from radiological examination, especially from CT that was absent 20 years ago, but now is more and more present in everyday clinical practice. And the CT is one of the major contributors to radiation exposure for this kind of pediatric patient. And so we have set in our scanner pediatric protocol according to the shape, as already said. Why we have to do that? Because if we use the same brain CT protocol in adults and children, the absorbed dose vary from 4 times more. An adult absorbs 1.5 millisievert for brain CT. A pediatric patient absorbs 6 millisievert for brain CT. That is a really huge amount of radiation dose. And for this reason, it is important having a good relationship with pediatrician in order to choose the alternative imaging modality and preserving the CT exposure for patient according to abdominal pathology, follow-up study, and so on, because we are informed to an increased lifetime exposure. I would skip this example, but I would like to show the last two patients from our center. This was a preterm newborn, 25 weeks plus 2, and this patient underwent several X-ray examinations at our center, at least I think 15 or 18 day by day, and we were able to recognize this area of radiolucency in the upper part of the right lung, but we were not able to make the precise diagnosis because the patient was a positive ventilation, he could have a bronchodysplasia, but obviously the X-ray is not enough to be so precise. And so at the end, our physician asked us to do the CT scan. We did it, and we are able to recognize this multi-cystic air alteration in the upper part of the right lung, without any precise communication with bronchus, and so our colleague make the correct diagnosis of bronchopulmonary dysplasia. Why I'm showing this case? Because 2 years ago we installed in our center a new CT scanner with deep learning-based reconstruction algorithm, and for this kind of examination we gave only a really few amount of radiation dose. The quality of the images is really high. You should think that the width of this lung looks like a lemon, was 5 centimeters, the entire lung, but with a really few dose, 0.5 millisievert, we were able to make the diagnosis. Unfortunately, during the hospitalization, the patient did a lot of chest X-ray. So for me, it's most important to do the best examination as fast as possible, making the diagnosis and then decide how to follow up the patient. This condition usually resolved by itself without any positive ventilation anymore. So we have to work in line with the ALARA principle that is typical for the radiologist. But don't forget to suggest to the clinician the AFARA principle, as few procedure and few examination as possible to making the diagnosis. Because in our clinical practice, at least from 10 to the 30% of CT scan can be useless. And so in the clinical practice, the most important thing is to maximize the diagnostic benefit while minimizing the radiation exposure. So we should use appropriately our different technique. And now I would like to thank you, for your attention.
For this spectacular overview of pediatric radiology.
Yes, it's a huge.
Also for the nice cases. Very, very excellent case.
I don't know if you are lucky or not in this case. It depends.
For didactic purposes, we are absolutely right. And I would like to call Mr. Dulia for any comments.
Thank you once again, Professor Ippolito. Very nice cases, very nice messages, and thank you especially for the last message about radiation dose in pediatric patients. It is really important, as you mentioned exactly, to maximize diagnostic accuracy so our pediatric patients get a proper diagnosis with the minimum amount of radiation. There is a balance, of course, there is always a balance, but the goal, as you mentioned, is to maximize the diagnostic accuracy and minimize the radiation dose for the proper diagnosis. This is really important message for the conclusion.
When you will start here, you should set all of the protocol because it is mandatory according to the age and shape mainly.
That's absolutely right. That is absolutely right. I don't have any further questions on the presentations. They were very excellent, and thank you so much for your insights. Extremely valuable and inspiring for all of us. And I apologize, I was not able to be with you in person today. I had a small but happy pediatric emergency on my own at home. I am caring for a newborn baby. I recently gave birth. So
I'm happy for you. And
thank you.
Me as well.
Thank you.
So
Thank you.
Father, as you, so I have
Thank you.
kind of emergency.
You both practice
Exactly.
Thank you. And I really hope that this will be the beginning of further collaboration between our institutions in the future. So thank you very much.
Thank you. And congrats again.
Thank you.
Thank you.
I would like also to thank both of you, especially, of course, David, for this enormous amount of information. For me, it was the biggest doses of pediatric radiology I ever had. So it was we saw almost everything. As I think for the residents, especially, to have your talks on the YouTube address we have for all talks would be very valuable for examinations in the future for everybody. So thank you very much.
I think it's not enough, but for pediatric class.
We have next year so in front of us. If you both choose some interesting topic, we can
Okay.
expand. Thanks a lot.
So, is there any question or comment? So, thank you very much.
Thank you for the invitation again. It's always a pleasure to be at this university.
Thank you.
Thank you so much.